All right, guys, this is Mrs. Fisher. I'm going to do a endocrine and diabetes review of everything from this module for you guys. You can watch this kind of before you test if you would like to. So first we're going to look at hypopituitarism. So manifestations of this are going to be abnormalities in like menstruation or fertility, specifically in women. You're also going to see both for manifestations and diagnosis, you'll see decreased levels of growth hormone, which is going to cause decreased bone density, and it's going to increase our risk for fractures. You have decreased levels of cortisol and aldosterone, decreased blood sugars. You're going to be more irritable or an inability to handle stress. It's going to increase your infection risk. You're going to put out a lot more fluid. So putting out fluid means you're going to decrease your sodium. So decreased sodium and decreased fluid volume are going to put us at risk for like hypovolemia or like risk for low BPs. You're going to have an increase of osmolality of the serum, increased potassium. So remember, when your sodium goes one way, potassium goes the other. So your potassium is in fact going to go up. And if this is because of a tumor, you might see headaches, visual changes, things of that nature. So overall, you're going to see a decrease in the hormone levels. Medication. So really medications that look at this are to replace based on the low hormones. So essentially what hormones we see that are low, we're going to need to replace that. Same with like sodium. If our sodium is going to be low, then we might need to supplement sodium or medications potentially to even treat high potassium. So Lokelma or things like that that are going to help pull potassium out. Complications. So everything is low, which our biggest complication is probably going to be that fluid volume deficit or that decrease in fluid volume, which actually causes a decrease in circulation. So we could actually have circulatory collapse. You're going to have a decrease in TSH, which is going to decrease your metabolism. That can cause hypothyroidism. So you might see like cold, dry hair. Skin and nails are brittle, weight gain if we get to that hypothyroid state. Priorities, we really need to prioritize our fluid loss here because we're losing fluid due to that aldactone being low. So we're concerned for circulatory volume or circulatory collapse. So we need to make sure that we are encouraging fluids in our patients and replacing that sodium. Usually you're going to see us replace with like a isotonic or hypertonic solution because we need to improve those sodium levels. We have to change sodium slow. We can't change the sodium too fast because that puts us at risk of things like intracranial pressure increases. We also need to get that potassium down. If our potassium's high, it causes potential risk for cardiac dysrhythmias or even cardiac death. And we're at risk for injury due to that loss of growth hormone. So we're at risk for that fracture due to that bone density. Your patients also are going to experience some activity intolerance. So monitoring for that and being able to help your patient perform their ADLs, as well as that infertility, specifically in women. Your patients may need to seek treatment for infertility issues moving forward. All right. Hyperpituitarism, you're going to actually see an increase in those hormones. So an increase in the ATCH, an increase in the cortisol and aldosterone. And the signs and symptoms are going to be similar to Cushing syndrome. So remember, when we have Cushing's, we have a cushion of hormones. You're going to see increased blood glucose, increased cortisol. You're actually going to get fluid retention due to the sodium. You're going to have high sodium. The blood's going to be diluted due to that fluid retention. So you're going to see decreased potassium. Increased bone density is going to cause that bone deformity in those deposits. So just like in acromegaly that you can see, that coarse facial features. So their hands and feet getting larger, that prominent change in the structure of the bone of the brow, things like that. Women are going to have irregular menstrual cycles, and you're going to see an increase in TSH. So you're going to get that hyperthyroid state. So it's going to increase your metabolic rate. You'll have weight loss and things of that nature. If it's related to tumor or injury or infection, you could have headaches, visual changes, and things of that nature, similar to hypopituitarism if it's caused by a tumor. So diagnosis is really going to be based on those hormone levels. You're going to see an increase in those hormone levels that we talked about, that that ATCH, cortisol, and aldactone. Medications, really, we're looking at things that just inhibit the hormone release and or decrease the tumor size. Complications, so just like in hypopituitarism where we're worried about fluid volume deficit, here we're worried about fluid volume excess or fluid volume overload. It's going to cause perfusion issues, that increased blood glucose caused by that increased cortisol. We're also going to be worried about high BPs or increased blood pressures due to the fluid. Once again, we talked about the changes in the facial features and the bone structure. Thyroid toxosis, or thyroid storm, those are big ones too. Usually you have to see that like medical emergency treated in the ICU. Your priorities are gonna be fluid restriction here for your patient. So strict I's and O's, strict fluid restriction because of the fact that they're gonna retain so much. So any little bit that they're drinking, getting IV, whatever the case may be. We need to monitor our blood pressures and our glucose pretty closely. We need to get our electrolytes back in balance. So we need to decrease that sodium. Remember, we have to decrease sodium slowly. And also, we need to increase our potassium. So potassium supplements, maybe educate on low sodium, high potassium diets. If your patient has any pain due to this being from a tumor, we would need to manage the pain or any visual disturbances they may have due to that. Hypocystectomy. So, really here what we're looking at is you have uh, the transphenoidal, which is through the nose, or the sublabial, which is through the upper lip. So really what we're looking at here is mainly looking for the care you're going to provide. So one going through the nose and one going through the incision in the upper lip. You need to really prioritize mouth care. If your patient goes through the nose, which is the transphenoidal, so they're going to have their nares packed. So both of the nostrils, one side or the other, may be packed or both. So monitoring for being able to breathe. They may become mouth breathers. They can feel anxious when things are stuffed up your nose like that. Our biggest thing here for complications wise is watch for signs and symptoms of meningitis. So that increased temperature, stiff neck, some nursing care that we can provide is elevating that head of bed, monitoring for cerebral spinal fluid leak, changes in the CNS, or levels of consciousness. And really, this is more just about managing care, medications you may be treating pain, secondary to the procedure, Tylenol, ibuprofen, whatever's appropriate. And then really monitoring for those signs and symptoms of meningitis and your nursing considerations for how to help with potential intracranial pressure changes. Okay. Diabetes insipidus. So diabetes insipidus manifestations are essentially that lack of antidiuretic hormone or vasopressin. You're going to see increased urination, which is going to ultimately cause you to become dehydrated, right? Because we're going to pee off so much fluid that we're going to become dehydrated. Your serum is super concentrated, so it's decreased osmolality, a decrease in specific gravity of the urine. You're going to have increases in sodium, increases um, in potassium, polyuria, polydyspnea, that nocturia where you get them have to pee multiple times a night, the signs and symptoms of dehydration, so dry mucosal membranes, the decrease in skin turgor. You have a decreased blood pressure, so because we're peeing off all that fluid, we're going to become hypovolemic, have that low blood pressure, and then the compensatory state of that is that our heart rate's going to go up, so we're going to become tachycardic. Your patient's going to be really tired. And this is going to decrease their circulation, right? Because we don't have enough fluid volume to circulate. Diagnosis is going to be high potassium, high serum osmolality, decreased urine osmolality, and decreased specific gravity. And then the biggest diagnostic test that y'all need to remember for this is the water deprivation test. essentially where your patient goes without water and you watch their output. Usually, despite giving them water and no fluids, they end up still having lots of urine output. Remember, we're still at risk for dehydration when we do this, though, because we are purposely depriving them of water and fluids to see how much they output. Um, and so they're still going to output a bunch with no intake. So we got to monitor for dehydration, okay? Your meds are going to be a desmopressin or synthetic vasopressin. Essentially, we're replacing the hormone that we don't produce, that we don't have enough of. Our complications are fluid volume deficit, dehydration, and circulatory collapse. You're going to see those signs of the increased heart rate or tachycardia and low BP, and then that high sodium and potassium too. So we need to monitor our electrolytes and get those back down in a safe balance so that we don't cause the complications of either one of those being out of range. Syndrome of inappropriate antidiuretic hormone. So this is the opposite of DI. The manifestations are going to be too much antidiuretic hormone or vasopressin. So we're going to have a decrease in urine output, an increase in blood pressure. The urine is very concentrated, so the osmolality is up, the specific gravity is up. The serum is very dilute because we're holding on to that fluid. We're not peeing it out, so we're going to have a very dilute serum. So we're going to have decrease in electrolytes. You could see a bounding pulse, headache, and you could see confusion due to the fluid retention and decreased sodium. So sodium under 120, you guys need to remember that that automatically should reflect seizure precautions. We could even end up in a coma from decreased sodium, and sodium's less than 120. And we're also at risk for cerebral edema, so that's swelling. Meds typically are going to be like a 3% saline, so lots of salt concentrated saline. Dimethylcycline and diuretics like furosemide, or the brand name Lasix. You guys should know it as furosemide. Those are going to help us with this fluid retention. It's going to help us pee off some of that fluid. Complications pretty much are that seizure, the coma, or cerebral edema, and an increase in intracranial pressure. We're also looking at potential severe hypertension here. So we need to prioritize like electrolyte, seizure precautions, and strict INO and fluid restrictions on them. Okay. Adrenal cortical insufficiency. So what we're looking at here is this is essentially adrenal hypofunction or Addison's disease. All of that can be used interchangeably. Remember, I like to remember this Addison's disease, we need to add more hormone. So adrenal cortical insufficiency or Addison's disease is caused by the sudden drop of um, cortisol. So where you no longer produce cortisol, you can actually even see this like a sudden drop of cortisol by abruptly stopping corticosteroids. So those medications really need to be tapered, very specific. You can't just stop corticosteroids without tapering off because you could actually put yourself into adrenal cortical insufficiency. This is going to be diagnosed with like a low cortisol level, low aldactone levels. You're going to see those signs and symptoms of Addison's disease, such as the change in skin color uh, due to the melanocyte hormones that all happen in the same spot. You'll see weight loss. They'll be very dry due to the decrease in aldactone, excessive urination, decreased sodium. When we're, peeing off a lot, we're going to lose a lot of sodium too. Concentrated serum, increased serum osmolality, an increase in potassium, a decreased urine osmolality, and a decreased urine specific gravity. So medications we're going to see are typically hydrocortisone or dexamethasone. We're replacing that cortisol and aldactone levels. Remember, those are your steroids, okay? Complications are going to be fluid loss and sodium loss, which is going to cause us that hypovolemic state again. So decreased BP, increased heart rate, potential circulatory collapse, and then that decreased sodium can cause us the seizures. Increased potassium can be bad on your heart. It can cause us dysrhythmias or even cardiac death. So we have to monitor for that really closely. One of the big things when you are doing medication management on these patients is to remember that if they have like an illness, an infection, or they're in like a high stressful situation, they've had a recent life change that's very stressful, something of that nature, we need to increase their meds because we need to match what the body would naturally do. So when you are sick, when you do have infection, or when you um have a stressful situation in your life, your body naturally is going to ramp up your cortisol. So we need to make sure that their replacement medicines match that. So what's going on in their life, they really need to communicate with their doctor when things like this happen, okay? And we need to prioritize electrolytes and fluid volume here. All right, adrenocortical hyperfunction. This is also called Cushing's disease. Remember I said earlier that Cushing's syndrome or Cushing disease is a cushion of hormone. So we have too much hormone. So what we're going to have here is increased cortisol, increased blood glucose. You're going to have an increase in weight gain, decreased muscle mass. You're going to have that moon face, the buffalo hump, the striae on the stomach due to that you have like central weight gain there in the abdomen. Your patient's going to have an increase in weakness and fatigue. They're going to have fluid retention. They're going to hold on. You might even see like non-pitting edema due to the levels of aldactone, increase in sodium, increased serum osmolality, decreased urine osmolality, and a decreased potassium. Medications, we're going to suppress the hormone output. You could also get an adrenalectomy. So the thing is, if you get an adrenalectomy versus meds, if they only take partial, your body may compensate and continue to produce hormone. However, if they take it the whole thing, the entire adrenal gland, most likely you're going to be on lifelong replacement. You're going to have to replace that hormone if they take the full thing. Some of your biggest complications from this are going to be fluid overload, decreased immunity, increased blood glucose, electrolyte imbalances, and skin breakdown. You're going to need to monitor eyes and nose really close. We might even put your patients on furosemide as long as other meds to suppress those hormones in order to help get that fluid volume down, help you pee off some of that fluid, okay? All right, pheochromocytoma is essentially a tumor of the adrenal glands, okay? So it's in the medulla of the adrenal glands. Manifestations are going to be due to release of the extra catecholamines, which is like your epinephrine and norepinephrine, or your fight or flight. There, we're going to see severe increase in blood pressure and heart rate. So your vital signs are going to ramp up. We're going to have a widening pulse pressure, have severe headache, hyperhidrosis, or that sweating, that perspiration, an increase in blood glucose, and an increase in metabolism. So this is firing your body into that fight or flight where it ramps everything up all at once. Meds we're going to use, we might use medications to lower the blood pressure and heart rate. And then the adrenalectomy, we talked about that in the previous slide. That would be the complete removal of the adrenal gland. Complications are really that severe hypertension that lead to cardiac death. So we really got to make sure we monitor and manage and get that BP and that heart rate back down into safe levels. So we're going to lower that BP. Priorities are going to be a low stimulus environment. We really want to try not to cause our patients any more duress or stress in their life so that we don't cause their vital signs to continue to ramp up and work their heart really, really hard. And then prep your patient for the adrenalectomy. So all of your pre-op stuff there. All right. Hypothyroidism. Hypothyroidism manifestations here and diagnosis are going to be based on hormone levels. So you're going to see a low T3 and T4. So that's going to be for metabolism. So everything's going to be low and slow. So weight gain, non-pitting edema. You can even see that orbital edema. You could also see larynx or tongue edema, which will cause like changes in their voice, so like a coarser or hoarse in their voice. The skin's going to be dry. The hair and nails will be brittle. Patient will be cold all the time, and you're at risk for skin breakdown here. So you're going to have a low T3 and T4 and a high TSH for primary hypothyroidism. That's because it's going to be trying to compensate. You could see an increase in cholesterol. You can see thyroid antibodies, and then there's also some scans we can do to diagnose. So meds here, so if we have hypothyroidism, we're going to be on levothyroxine, or Synthroid is the brand name. When I hear Synthroid, I think synthetic thyroid. So some of the education here is that it's best if your patient takes it on an empty stomach before meals, usually about the same time early in the mornings. All that really is doing is if you don't produce enough thyroid hormone, we have to replace it. However, we need to monitor those levels closely, because if we are supplementing the thyroid hormone, we could actually cause hyperthyroidism. So make sure that we are monitoring our T3s and T4s. One of the big complications you can get here is called myxedema, which is a decreased heart rate and increase in edema. You can see a decrease in temperature, cardiac issues, and potentially loss of consciousness. This could even lead into myxedema coma, and you have a decrease in metabolism too. So we really want to prioritize monitoring those med levels, those hormones, cardiac edema, and watch for signs and symptoms of altered mental status so that we could catch it before it becomes myxedema coma. All right. Hyperthyroidism on the opposite end here is going to be hyper, everything's up. So increased T3, increased T4, decrease in TSH. Patient's going to be hot, fatigued, insomnia, increase in blood pressure and heart rate. It's going to ramp everything up. Tremors, muscle weakness, irritability, and bulging eyes. Medications are going to be cyanamide, which inhibits thyroid hormone release. You could see iodine or radioactive iodine. It's actually going to destroy the hormone producing cells. And then your patient might even go on beta blockers for heart rate. Complications here are if we don't treat hyperthyroidism, we can end up in that thyroid storm. So we need to monitor for like increased temperature and chest pains. Big priorities here to monitor our cardiac status, our BP, and our heart rate. A partial to a full thyroidectomy too. Remember, if we get rid of the thyroid completely, then we are probably going to go on thyroid replacement that we need to balance really close. So once again, once we get rid of that thyroid, then we become hypothyroid, and we have to start that process there with the levothyroxine, okay? If your patient gets a thyroidectomy, monitor for bleeding. Because it's in that area where the trachea is at, you could actually get tracheal compression due to like a hematoma or edema in that area, so monitor for that. And then signs and symptoms of hypoparathyroidism, which we're just about to talk about. So here it is, hypoparathyroidism. So manifestations here are really the low calcium and high phosphorus. So remember, when we have low calcium, we get that tingling, numbness, that Chauvet sign or the Trousseau sign. Cardiac dysrhythmias, because we got to have calcium right for our muscles. And then bone deformity. So bone deformity we're going to see because our body is actually going to try to pull calcium from the bone, going to make us weak bones. Meds here we're going to replace with calcium and vitamin D, and really just complications of things from the low calcium that you have there, okay? Hyperparathyroidism. So the opposite here, manifestations and diagnosed off of high calcium levels and low phosphorus levels. So you're going to see muscle weakness, fatigue, like calcium kidney stones, lethargy, fraction, you can see fractures. Your patients end up with a lot of bone pain. Right here, we really need to monitor for cardiac. We need to decrease that calcium in the system, watch for that fractures in the bone pain. Not too much there to remember for these, okay, guys? Type 1 diabetes. So really, type 1 and type 2 diabetes, we're going to touch on them just a second, but for these, reference back to the primary lectures that you guys have got. There's some things to look at there. Know your like 3 Ps, your hyper and hyperglycemias, diagnosis-wise for type 1 diabetes, and similar for type 2, knowing your finger sticks that postprandial or the random finger stick of greater than 200, a blood glucose of greater than 126 for fasting, and that 6.5 or greater for the hemoglobin A1C. That's going to be for both type 1 and type 2. That's all you're going to need to know. You're not going to need to know the pre-diabetic. Medications for type 1 is going to be insulin. Big thing here is don't remember you don't mix long-lasting insulins. Go back in your lecture and review those slides on peak and onset. Remember that insulin is sensitive. We need to make sure we are drawing it appropriately, giving our patients the right amount. Complications of giving insulin, we're at risk for hypoglycemia if we give too much insulin. So make sure you know that. And then a big complication that we get here for type 1 diabetics is DKA, which is a blood glucose of greater than 250, a low pH, a low bicarb, and an increased amnion gap. And then you'll expect ketones. Remember, you can like smell that sweet on their breath and the ketones in their urine. And your priorities here are to prevent those complications and monitor for the hypoglycemia due to the insulin. Okay. And then type 2 diabetes, need to know metabolic syndrome, the hypo and hyperglycemias, the finger stick stuff, like I just said, is all going to be the same. Meds, so metformin is actually going to decrease insulin resistance and increase the sensitivity. So really there's not a lot of risk for the hypoglycemia like you get with insulin injections. Remember, type 1 diabetes is the lack of insulin production from the pancreas. Type 2, we have insulin, but we've become resistant to it. So insulin is like a key that unlocks the cell. So the door to the cell, the key no longer fits the door, meaning we can't unlock the cell to get the insulin in so that we can use it for sugar, correct? So we no longer we have keys, but they don't fit the locks versus in type 1 diabetes, we don't make any keys at all. Some things with metformin to remember is that they can cause pretty severe stomach irritation and weight loss. Your patients might have nausea or vomiting, diarrhea from it. And the big thing here, if your patient's going to have scans or they're going to be pre-op or post-op, 48 hours before or after receiving contrast dye, your patient needs to hold their metformin. Metformin and contrast dye don't like each other when it comes to your kidneys. It'll cause pretty severe issues on your kidneys. So no metformin 48 hours before or after receiving contrast dye, whether it's for a heart cath, a CT scan, whatever it may be, okay? Complications here are HHS, blood glucose greater than 600, no ketones, dehydrated, increased serum osmolality. And then the big rule here for the diabetics, remember on their sick day rules. So sick day rules for diabetics that if their blood, they're going to have increase in blood glucose testing. So they need to be checking their sugars more often than they normally would, 4 hours or more. If you've had vomiting or diarrhea for longer than 8 hours, you need to call your provider or your doctor. You need to really stress foot care with your diabetics, watching to make sure they don't have sores on their feet. They get those from that diabetic neuropathy. They can't feel that they've stepped on something, that tack, they step on it, they don't realize it, then it becomes an unhealing wound, and then that wound becomes, a sore that leads into the osteomyelitis, infection in the bone, amputation. So it's really important that we make sure that they check their feet. We educate them on checking their feet regularly, wearing shoes around the house, that kind of stuff. And then the exercise rules, remember that if the blood glucose is less than 100, they need to eat, or if it's greater than 250 or they have ketones, they need to hold exercise for a while. Okay? All right. And if you guys have questions, comments, or concerns, feel free to email me kfisher@astate.edu. Okay. Thank you guys.